Specialty Hospitals, Chennai, the Emeritus Editor of IGPP, co-editor of Essentials of Pediatric Pulmonology in 2008, editor of the Management Guidelines for Common Pediatric Problems, master trainer of Asthma Training Module RTA GEM, who's done more than 2,500 flexible bronchoscopies in children, to deliver his talk on bronchoscopy, a journey through lungs. Over to you, sir.
Thank you. Am I audible?
Yes, sir, audible.
If the videos are not playing, just interrupt me then and there. Thank you. Bronchoscopy,
Okay, sir.
a journey instead of through the lung, I have modified to a journey to lung. My humble greetings to all my teachers for helping me to come to this level and team IJPP. This child with frequent respiratory tract infection and chronic cough. You are able to see a bifid epiglottis, the reason for frequent RTA and chronic cough. It's a developmental anomaly. Flexible scopy can diagnose congenital anomaly. This child with stridor but good weight gain, with a noisy breathing, which was the worrying factor. You look at the omega-shaped epiglottis, the foreshortened ariepiglottic fold. You see the glottic opening getting closed by collapse of the posterior supraglottic apparatus. So laryngomalacia. Once again, scopy diagnosis. This is a 5-year-old child with sudden onset of respiratory distress and noisy breathing with a fever of 3 days duration. Kindly look at what is happening to the right side of the supraglottic apparatus, vocal cord, ariepiglottic fold. It is moving very less compared to the left side. So here you have a right vocal cord palsy and it suggests a neurological issue. MRI in this child showed ADEM. So flexible scopy paves way for non-respiratory illness, for diagnosing non-respiratory illness. This child, 5 months old, referred for low voice volume. Anyone will be able to diagnose this by one look. This is a laryngeal verb, but it appears thick. It enters up till the subglottic region. So for diagnosis of laryngeal problem, flexible scopy can be used. This is a 5-year-old child who has breathlessness, Harrison sulcus, accentuated second heart sound. Echo shows pulmonary pressure almost equal to systemic pressure. Look at the scopy. What do you see here? The vocal cord shows papilloma, like you are able to see the papilloma, but from inside. If you are going to come from inside, from the trachea, you see it extends up to the epiglottis. This is the extent of the papilloma, undiagnosed, and it has led on to pulmonary hypertension. So flexible scopy can diagnose etiology. 7 months old child with frequent stridor settles with adrenal nebulizations for short time. Child had an intubation in neonatal period, failure to gain weight. What do you see here? You have granulation tissue in the subglottic region along with a cyst. You have a subglottic cyst with granulation, probably post-intubation. So flexible scopy is a must in those infants with respiratory noises. This is another child, 13 years old, breathlessness frequent, treated as acute asthma with salbutamol and oral corticosteroid. His saturation was low. He prefers not to be disturbed. He sleeps only in the semi-recumbent posture. You have a look at the X-ray. You see the tracheal cutoff sign. You are not able to see the tracheal air column beyond a particular point. You look at the scopy. See, the trachea is compressed from side to side. This, through this narrow part, which allows a scopy of 2.8 mm to pass through. This is the space through which he has been breathing through. With antituberculous treatment at the end of intensive phase, look how the endobronchial granulation had subsided, though the MGIT culture was also negative. So if flexible scopy is a must in poor response to treatment with acute asthma. This is an 8 months old child with 5 admissions, the last 2 admissions in PICU, the last admission needing 8 days of ventilation. He is visiting the 4th tertiary care center since 1 month of age. You have a look at this one. This is taken as pre-op with a rigid scope only for teaching purpose. Why? Because this is the esophagus, the so-called the H-type fistula. This is the one. You see the esophagus on the left side. You see this opening through which you see a tube. This is the endotracheal tube. Just before they opened up the surgery, they opened up for TEF surgery. So this is how a TEF looks. This is done with the help of a rigid scopy. So you can diagnose H-type fistula with flexible scopy. This is a TEF operated child. The problem was frequent vomiting, respiratory distress, scopy. Just look at the scopy. You already know, with one look at this child, you know this child has got a laryngomalacia. But look at down below, what is there? You look at the trachea, it is fish mouth shaped, that is a tracheomalacia. Not only that, look below, down, near the carina. You are able to see, once again, compression of the right main bronchus along with the opening of the H-type fistula which has been operated. So not only one lesion, many lesions, congenital airway anomaly can coexist in a single child. Flexible scopy must in aerodigestive tract anomaly. This is the child who had third admission for pneumonia, not a partial response to antibiotics. Basic investigations normal, X-ray shows bronchopneumonia. You look at the trachea, look at all the white patches sticking on to the tracheal wall. We did a bronchoalveolar lavage. All these white things turned out to be candida, so helps in diagnosis of candidiasis in the respiratory tract. It gives a clue to the diagnosis of immune deficiency. This is a 10-year-old child who has violent cough and sudden choking. Within seconds, he reverts back once again to cough. X-ray is normal. Look at this. This is a mobile foreign body with a sitafal seed, which during each cough, it comes and closes the glottis. Life-threatening, but scopy diagnosis helps in a child who has cough, chronic cough. This is a 10-month-old child. This child, grandmother gave groundnut, sudden violent cough. Child started wheezing, home nebulization by the mother because child had had past wheeze. The cough was persistent, did not allow the child to sleep in the night. During travel to hospital, the child coughed and then started sleeping. This is the scopy. This is the left main bronchus, secondary carina. You look at the mucosal ulceration here. So mucosal ulceration on either side. This is indicative of something gone inside the tracheobronchial tree, getting stuck there and with violent cough, getting coughed out. Cough is a normal defense mechanism which tries to remove everything except air. So a negative scopy also is as important as a positive scopy. This is the last case, 10 years old child, fever of 3 days, cough for 10 days. Look at the X-ray, there is mediastinal shift, pneumonia, collapse of the left lower lobe. You are able to see not only collapse, but also a lot of cavities. Look at this scopy. You have pus everywhere and go through the pus, you aspirate, and then you see endobronchial granulation. You do a bronchoalveolar lavage. What do you see? CB-NAT positive tuberculosis. Gram-Stein shows, gram-negative bacilli culture shows Pseudomonas aeruginosa, and fungal culture shows Aspergillus niger, all three in the same child because of the cavity, long-standing duration, which the patient was not able to realize. Genetic testing for primary immune deficiency is negative, MTB culture positive, all first-line drug sensitive. So if flexible scopy with BAL is a must in atelectasis, and BAL can be a game changer. Flexible scopy can be therapeutic, where in a child who has atelectasis 2, just look at the thickness of the secretions which we are able to aspirate from the left upper lobe in this particular child. You are able to see this thick mucus plug which the child was not able to take it out from his left upper lobe. So it can be therapeutic in especially ventilated children with atelectasis. So carry home points, mainly diagnostic, but few therapeutic modalities can be done with flexible scopy, including mucus plug, foreign body removal, cryo sometimes to remove endobronchial lesions. Thank you.
Thank you, sir, for that illuminating presentation. Now we have a few questions from the live session.